Hello, everybody. I'm Dr. Keith Marth, the Executive Director of the Consortium of Universities for Global Health. Welcome to today's CUGH webinar on the impact of COVID-19 in Africa and Latin America, challenges and opportunities. We know the COVID-19 pandemic has been a global health and economic crisis rooted in environmental degradation due to human activity, causing the spillover of the SARS-CoV-2 virus to humans. The impact that we've seen has been devastating worldwide, but no more so than in poor and low-income communities around the world. This is severely testing health systems everywhere, but particularly in those countries that already have overstretched health systems. But this is also an opportunity to strengthen public health systems, to strengthen public systems, and to address some of the environmental challenges that underpin this spillover. It's a chance to improve the social determinants of health. And to talk about this today, in two parts of the world, in Africa and Latin America, we're very privileged to have three innovative leaders. In the order in which they'll speak are Dr. Nelson Torto. Dr. Torto is the Executive Director of the African Academy of Sciences in Nairobi. He'll be followed by Professor Lillian Dudley. Professor Dudley is a professor of public health at Stellenbosch University in Cape Town, South Africa. And Dr. Dudley will be followed by Dr. Patricia Garcia. Dr. Garcia is the former Minister of Health in Peru, and also she is a professor of public health at Cayetano Heredia University in Lima, Peru. So it's my great privilege to turn it over to Dr. Torto. Dr. Torto, welcome, and over to you.
Thank you very much, Keith. It's an honor for me to be part of this webinar, and I'll be very happy to discuss some of the issues that we have been addressing as the African Academy of Sciences. And firstly, I just want to give you an overview of who we are as the African Academy of Sciences. As you said, Keith, we are based in Nairobi. We are a non-aligned, non-political, not-for-profit Pan-African organization. We are the only continental academy in Africa, enjoying the support and recognition of the African Union. It means that we have got very good relationships, not only with African Union as a body, but also with several governments. The government of Kenya, the government of Nigeria, the government of South Africa, the government of Botswana, and the government of Rwanda, just to give some examples. We also have very good partnerships with international organizations as well as governments which are abroad. For instance, the German government, the UK government, and we've got partnership with Wellcome Trust, Gates Foundation, CEDA of Sweden, the Carnegie of New York, just to give you some of the examples. So in terms of the constitution of the African Academy of Sciences, the mandate is really divided into three pillars. The first one concerns recognition of excellence, and recognition of excellence concerns the way the academy brings in the different fellows into the academy. We also have an opportunity to be able to bring in people who have done work that we feel that is aligned to the objectives of the academy, and those come in as honorary fellows. This could be previous ministers in government. This could be former prime ministers or presidents. The second aspect of the mandate concerns think tank related activities where we deal with governments and regional economic communities to address issues of policy, evidence, and how this can help governments in terms of their work. So the other issue, the third one that really consumes more than 80% of our time, concerns the implementing of key science, technology, and innovation programs. So as you would expect, we are an academy of all sciences, and because of that, we, like any organization, we have got a strategy. Our 2018-2022 strategy focuses on 5 priority areas: natural sciences, social sciences and humanities, policy and governance, environment and climate change, as well as health and well-being. So one of the things that one would have noted is the fact that we rely very much somewhat to look at African data on the basis of the CDC in Africa. And you can see from this slide that we have had quite a lot of cases for COVID-19 particularly in the south, in terms of South Africa, and also in the northern part. And of course, this could also be a reflection of the different capabilities that the governments have in terms of being able to test and monitor. But what is very clear is that just as recently as yesterday, we can see that the cases have increased. And one thing that has been unique in Africa that has not necessarily gone according to prediction is the fact that we've had a high rate of recoveries and very few deaths in the countries that are affected. And this is quite positive. I know in Botswana, for instance, that we've only had one death associated with COVID-19, and most of the cases that has been recorded have recovered, and we only have 5 that are still in hospital. So from an African context, I think one will have to look at various factors that need to be considered. We know that in Africa we are a leading continent in terms of the burden of disease, as Keith has said in the introduction. Obviously, it's an issue of resources, and the continent is poorly resourced. There's also an issue of food insecurity. As we are battling COVID-19, there has been, in the eastern part of the continent, there has been a serious destruction of crops due to locusts. And I was just reading the news today, and I saw that in Ethiopia, they're actually spraying in advance so that they can actually protect some of the crops so that they cannot be devastated. The famous slums in the continent are very well known, Khayelitsha in South Africa and Kibera in Nairobi. So poverty is a big deal, and obviously, given the requirements of COVID-19, where there has to be social distancing, it means that this presents quite a challenge in terms of how can this be handled. And of course, again, in East Africa now, it has been quite a heavy rain season, and there has been a lot of destruction of buildings, destruction of roads, and destruction of lives. So climate change, the impact is quite severe in the continent. But we still know that one of the issues that is there is that in Africa, rural dwelling is still higher than urban dwelling. So in a way, that somewhat gives it an advantage. But of course, the major aspect that is very important for the continent is that there is a youth demographic dividend, given the fact that most of the population is the young population. And because of that, I guess it presents a lot of resilience in terms of how the populations can cope with regards COVID-19. So just to focus to the main activities of the African Academy of Sciences, obviously, we function through our fellows. Our fellows are divided into several groups. And one of the groups that are very engaged is the group that concerns epidemic preparedness. And of course, the AIS is convening African and global scientists, policymakers, funders to discuss the pandemic in the continent and see what it really means for the continent and the rest of the world. Specifically, we are supporting the research base. I mean, as I said earlier on, implementing of programs occupies more than 80% of our time. We are trying to identify African research priorities so that we can really be able to help governments in terms of driving these and ensuring that they can get the best value for money in terms of what they embark on. We're also trying to identify relevant African research expertise so that we can really know who are the resource persons that can be counted upon in order to address the various concerns relating to COVID-19. We are also identifying ongoing and planned COVID-19 research activities across Africa. And we also want to play a role as the go-to trusted resource for policy, public and community engagement, so that we can really play the role of our mandate where we are advising African governments in terms of what they need to do. So what are the activities that have taken place through our influence since the announcement of the pandemic on March 11 by WHO? The first thing that we did was to convene a webinar. In fact, this was our first webinar of note, where we had about 275 scientists participating in the webinar. After the webinar, what we did was that we did now look at the WHO roadmap, where we exposed those components that were identified by WHO in terms of 9 sectors. So before the 8th of April, we were involved in a survey that had participation of about 844 people, 90% of whom were Africans or people working within the continent. And out of this survey, we were able to come up with additional 17 new priorities that are really specific to the African situation. And a report is available on the website at the African Academy of Sciences. So what else did we do? We also tried to convene and get a list of COVID-19 experts in the continent through our clinical trials community program, so that again, we can know how to engage with these people if there was need. And what we've also done is to try and engage with our partners to try and see whether we can really get some funding that can actually be used by researchers for COVID-19. And on May 1st, we did send out an announcement for funding for researchers to address some of the key issues for COVID-19. If you look into the 9 defined zones by WHO, from clinical characterization to ethical considerations for research, it is these 9 sectors that we expose to the researchers. And of course, we wanted to see whether we can be able to add to the 42 priorities that have been defined by WHO. And as I said earlier on, we're able to come up with 17 additional potential priorities, which would need now to be reprioritized so that we can see which one is key, which one should we go for. So these are some of the examples of additional African priorities developed for the survey. The first one is, to support the work that examines alternative approaches to delivering testing, which is very key. Also, the special focus on potentially at-risk groups. I think HIV, TB, malaria, sickle cell, these are concerns in the continent that are already making people lose their lives. So we wanted to see what impact this will have. We also wanted to develop protocols for management of several diseases in the absence of intensive care facilities, because we know Africa, in most places, the governments are not well resourced in terms of the facilities that they can provide for the hospitals. PPEs, we know PPEs have been a concern everywhere globally, and it's not different in the continent. But obviously, the issue is that people want to see how this can be made from locally available material, and also establish, ethical review for COVID-19 related research proposals, and look at optimal ways of communicating about potential interventions in high density areas, as I've alluded earlier on, like in Kibera in Kenya. So these are some of the issues that were raised by the researchers as we did the survey. And one thing that I want to bring to your attention is that as the African Academy of Sciences, the tasks that we do because of our aspect of implementing programs is that we want to try and assist researchers as much as possible. And we want to do that by providing different tools that can help them present themselves to the funders in a manner that due diligence process is transparent. So we developed a standard which we call the Good Financial Grant Standard. And through that standard, grantors or people who are giving funding, they can be able to assess the capability of an organization to handle money when they're looking at governance issues, procurement issues, finance issues. And on that basis, then they'll be able to see who they can give money to. So because of the fact that we normally allow people to have access to that standard at a higher rate in terms of the amount that we charge, we have decided that for COVID-related applications, the funders can be allowed to give access to the people who are looking for funding at a very reduced rate of $100, and this will allow the disbursement of funding to be very quick, and therefore assist the funders the researchers in terms of driving their research. So as a way forward, what we want to do, we want to continue with calls for research funding, so that as we get some funding from government or from partners, those who have got proposals that are eligible for funding, they can be funded. We also want to continue addressing issues of policy in the public, community, and engage with governments so that we can really have a priority list published for what are the key issues for research which should be driven. We also, through our clinical trials community program, want to develop a COVID-19 database of experts, the capacity to deliver the work, and also the ongoing and planned research regarding to COVID-19. And obviously, we want to convene engagements on research priorities so that really we can begin to form different clusters of expert groups that can be tapped from in terms of assistance to the continent. So clearly we want to develop multidisciplinary work packages that can release advisories for countries, and this should really be all encompassing. As I said earlier on, that we are an academy of all sciences, so we really want to look from social sciences, humanities, economics, as well as the health aspect. So really, this gives you some of the references that you can use in terms of getting in touch if you want more information. And with that, I'll conclude and pass it on to Professor Dudley. Thank you very much.
Thank you very much, Dr. Toto. So moving from the perspective of Africa to reflections on the experience of the COVID-19 epidemic in South Africa. South Africa was one of the first countries to report a COVID-19 case following Algeria and Egypt, and currently is the country reporting the most cases on the continent. We reported our first case on the 5th of March 2020, a traveller who had gone on holiday to Italy, and since then the number of cases has increased to more than 11,000. We have more than 200 deaths and have done more than 370 or close to 370,000 tests. The epidemic is projected to peak in South Africa between June and September, and we anticipate at least 50,000 deaths to occur. Now, our context is a large population, 60 million, of whom 9% are over 60 years. And the majority of the people in South Africa live in poverty, a large proportion in informal settlements, as well as in backyard shacks in urban areas. We also have a very high prevalence of HIV, most of whom are on treatment, but a large proportion are not. And we also have a very high incidence of TB, which are concerns which other countries have not experienced in the north. In response to the COVID-19 epidemic, South Africa established a national COVID council who developed the initial strategy and plans. And they based plans around South Africa having 3 waves of the epidemic. Firstly, the travellers from other countries, and then followed by contacts of those travellers, and then lastly, a 3rd wave where community transmission to the rest of the population would occur. The strategy of the council occurred in 8 stages. So going through a preparation phase of community education, establishing lab capacity, developing surveillance systems, to primary prevention through advocating physical distancing and hand hygiene, and at that stage also closing schools and closing the borders to international travel. South Africa also adopted a hard lockdown, which restricted the population to their homes and only allowed essential workers such as healthcare workers, food retailers, security services and transport services to operate. We then moved on to stage 4, where we intensified surveillance and mobilized community health workers to do active case finding through door-to-door screening, testing, and then also isolating cases and intensive contact tracing. So the course of the outbreak has really followed partly the phases that the council anticipated, and as you can see, we had our initial peak of travellers, but with the hard lockdown, we managed to control that quite successfully. And for a while, South Africa thought that we had in fact flattened our curve, and in fact also extended our hard lockdown to try and reinforce that. But unfortunately, subsequently, we have seen a rapid escalation in the number of cases. And at this point in time, we are seeing more than 600 cases occurring on a daily basis. So we've now moved into a stage of identifying hotspots and intervening in those areas. And in particular, we have found that the first hotspots have been workplaces. So all the essential workers who were allowed to move around during the lockdown have been the front line who contracted COVID initially. So food retailers, the security services, and then increasingly healthcare workers as well. We've also mapped out the cases in clusters and tried to intensively investigate and curtail those outbreaks. But despite that, we are moving into the phase where we are needing to provide more medical care. We have more than 500 patients hospitalized at this point in time, and infection prevention and control in hospitals has needed a lot more attention and support at this stage. South Africa has also managed to build additional field hospitals to support the existing hospital and bed capacity. And we've also looked at innovative ways to increase the capacity for ventilation. Increasingly, we are also moving into stage 7, where we now have more than 200 deaths. And just to describe some of the initial information of deaths that we've seen in the Western Cape, which has really been the hotspot of the COVID epidemic in South Africa. We are seeing a similar age trend to other countries, with most of the deaths occurring in older age groups, the over 60s. And we're also seeing that at least 60% of the patients who died have had comorbidities with other chronic diseases. We were expecting to see more HIV and TB in patients that had died. And at this stage, we are not seeing that, but it is still early in the epidemic, and we'll have to wait and see how that progresses. So a few reflections on what has and what hasn't worked in South Africa. Some of the activities in stage 1 to 3 worked extremely well, the closing of schools and the closing of borders and the lockdown, but particularly in high and middle income suburbs. We also saw very effective leadership from our president and government across sectors initially. We also had quite incredible civil society mobilization in solidarity with people affected and communities that were affected. What didn't work is that much of the initial focus didn't actually cater to most of the poorer communities, both in terms of cultural and language appropriateness of a lot of the education, and also the feasibility to be able to social distance or apply hand hygiene in communities which were very overcrowded, 5 or more people living in shacks, lack of access to running water, poor sanitation infrastructure, etc. There was also a very mixed messaging about face masks initially, which caused some confusion. As we proceeded towards the closing of schools and borders, a certain level of panic ensued, and large crowds focused on shopping, panic shopping, buying essentials from toilet paper to food to stock up. So as opposed to trying to social distance, we in fact had the opposite effect in many areas. And as the lockdown proceeded, we found that in many areas, people had tremendous difficulty adhering to the lockdown. As daily wage earners lost their income, more and more people became food insecure, and queues started developing for food parcels and food kitchens. More and more people required social grants, and government has expanded the social grant allocations to cover more people and supplemented those who already received grants. We also saw that funerals became gatherings where COVID was also transmitted, and funerals were allowed under our lockdown. One of the other unfortunate effects of our lockdown has been that the police and military have needed to try and enforce much of the legislation in many areas, and we have seen excesses of force being applied. We've also seen an unfortunate dramatic increase in the reporting of domestic violence as women and children remain in unsafe spaces and unable to leave them. In terms of the later stages of our responses, we made testing available extensively across the country, and particularly through the mobilization of more than 28,000 community health workers. However, the initial case definitions for testing were very narrow, and many symptomatic contacts or asymptomatic contacts weren't tested or were turned away. And our community health worker screening has not generated the levels of case detection we had hoped. Part of this has been that it hasn't been very targeted at clusters or around cases, and some provinces are now targeting community worker and community testing far more extensively. So some provinces have moved to far more active surveillance, case and contact tracing, and outbreak investigations, but these have also been hampered by a backlog in laboratory testing. As our laboratories have scaled up testing, we've started to run out of the reagents and ingredients required for laboratory testing, and tests often take 5 to 7 days before we can get the results. We've also seen what has been described as implausible trends in some provinces. The Western Cape has seen a dramatic increase, but many other provinces in South Africa have seen very little in terms of COVID at this point in time. Our attempts to flatten the curve were successful to the extent that it gave us more time to prepare medical facilities, to establish temporary hospitals, and to procure supplies. However, we do still have limited bed, clinical, and ICU capacity, and are competing for PPE and other supplies with countries across the world. And having no flights into South Africa has made this even more difficult. So our challenges, many of them are in fact around socioeconomic circumstances or social determinants, as has been indicated earlier. Surveys have found that food insecurity has become a huge dilemma for many South Africans. Living conditions make it very difficult to comply with lockdown, isolation, or quarantine requirements. Increasingly, people are losing livelihoods, and unemployment has increased to more than 40%. And in the face of this, the social relief response from government, even though there's been commitment, it has been slow to be implemented. And we've really not engaged communities extensively enough to counter some of the fake news and anxiety that COVID-19 has generated. From the health system perspective, South Africa has to date had relatively good outbreak preparedness, but the COVID-19 has really shown us where some of the cracks and the weaknesses are in our system. So in terms of international health regulations, we really are going to have to look at how we comply with these in terms of strengthening surveillance, our laboratory systems, our human capacity for outbreak preparedness and response. We also have a challenge in South Africa with a dual health system. The wealthy have access to private healthcare, so 20% of the population uses a well-resourced private healthcare system, whereas 80% of the population are using a relatively under-resourced public health system. And quality of care is therefore a huge issue, and in the face of COVID, very poor infection prevention and control in many facilities is going to be a challenge for us. Even though our laboratory system is an accredited and a very good one on the African continent, it has come under huge pressure, and we are now seeing these very long turnaround times. And we are going to look at how we use both the public and the private sector facilities to ensure that we can provide adequate bed space and ICU support in South Africa, and even that may not be sufficient. So what are the opportunities? We are hoping that the fact that COVID-19 has really thrown a glaring light on the socioeconomic challenges in South Africa is going to lead to a stronger commitment from government and other sectors to address the many problems that people in South Africa face. We are already seeing mobilization and talk about it, but we're hoping that this is going to translate into resourcing and action. From the outbreak and the health system perspective, we certainly need to further strengthen our outbreak systems and public health systems. We need to move towards universal health care and national health system, which South Africa has already committed to, but this is certainly going to create more impetus to move towards that and to improve the quality of care. Some of the other opportunities have been around the recognition that South Africa needs to produce more of our medical products and supplies locally. At the moment, some of the international patents are barriers to that, and there seems to be some advocacy around addressing some of those issues. So certainly, I think we felt that some of the global examples of addressing COVID in other countries has been useful in South Africa, but many approaches have not been suitable in our context. And certainly for other countries, some of the lessons are that responses need to be tailored to the context. Thank you. I'm going to hand over to Dr. Garcia.
Hello, good morning, everybody, and thank you for the invitation. So the first thing that I have to say is that there are so many commonalities that I can see from what is happening in Africa and from what we are seeing here in Latin America. And I will try to give you an overview of the whole Latin America in just 10 minutes. So let's see if this works. So in Latin America, on February 26th, Brazil reported the first case of COVID. And right after, in March 11, WHO declared the pandemic. By March 19th, every country in Latin America had reported COVID cases. And by now, we have more than 300,000 cases in the whole region, compared with the world, which is reaching, which is over 4 million. The epidemic in Latin America initially affected higher income groups returning from abroad and their close contacts, but it spread rapidly into the lower income populations that have less access to health services, and it definitely poses a major risk to the region. So let me tell you a little bit about the context in Latin America. So we are several countries, more than 20, that share many economic, political, social, and cultural issues. One of the issues, for example, are cultural norms. We're characterized by close personal relations and extended families, and very high rates of informal work. We also have health system similarities, with varying levels of universal health coverage. Many of our nations are experiencing long-lasting deterioration in several population health outcomes following economic and political shocks. And we have wide inequalities in income and effective access to healthcare services. We have indigenous communities, and we, as Latin America, we are the most inequitable region in the world. So what are the challenges in the whole region? So one of the issues is the rapid urbanization that we have been living on, with very crowded megacities. You can count them: Bogota in Colombia, Buenos Aires in Argentina, Lima in Peru, Mexico City in Mexico, Rio de Janeiro, and Sao Paulo in Brazil. And in these crowded megacities, we have also widespread poverty, and that means that we are congregated settings that are favorable for increased transmission of the viruses. The other important issue is that we have had just in these past years migration of millions of Venezuelans, and we have these migrant communities with inadequate living conditions that are settled in different parts of the city. Okay, we don't have areas that are exclusive for Venezuelans, but one thing that is clear is that they might be living in inadequate living conditions. We have political instability, and we have decentralization of health-related funding and decision-making to states, provinces, municipalities, or social insurance organizations that had led our health systems even more fragmented. Finally, there are relatively low levels of investment in public health systems and lack of enough trained human health resources that are usually mainly concentrated in the capital cities. And we have hospital systems with suboptimal capacity of intensive care units. And this is in general in Latin America, with some few exceptions of countries. And let me show you, for example, we have chosen here some countries, okay, and we're showing the number of hospital beds, intensive care unit beds, ventilators, and physicians per 100,000 inhabitants. I come from Peru, okay, and one of our biggest challenges is that by the beginning of the epidemic, we counted the number of ventilators and ICU beds, and it was not even 500, making a big effort at turning beds and trying to repair ventilators, and even with this wave of trying to produce new ventilators, we have been able to reach 900 ventilators. And so far at this point, we're using almost 720 ventilators with patients with COVID. So we have very little for other patients. So how has been the response to COVID-19? The evolution of the pandemic, as well as the nature and stringency of the response, had varied by countries. But one of the things that is quite important is that most countries in Latin America have responded early with multiple and well-sequenced measures. And I'm showing here a picture of a community in the Andean region in Peru, where they decided to close by themselves. I mean, the mayor of the city decided to put these big signs here, where he's not allowing anybody to enter the community. So they are locking down even by themselves. So what are those measures? So what has happened is that there have been mandatory restrictions even from the very beginning. Everybody started talking about social distancing and these issues of masks, hand washing, remote working, closure of schools and universities, banned social and religious gatherings, closure of shops, entertainment, and meetings, and this lockdown that has been in some countries even followed by curfews. And of course, closure of international borders and closure of national transportation. And let me show you this graphic, okay? I don't pretend you to read everything, but as you can see, from the start of the first cases in Brazil on the 26th, okay, and here you have the first reported cases from February 26, very early, most of the countries started having cases, and most of the countries started taking decisions very early, as I said, see around March the 16th. Most of the countries have decided to have lockdown and all these extreme measures. And what has happened, and what did it work? And what I wanted to show you here is what has happened with Latin American countries. So here you have some examples, okay? And this is the total confirmed number of COVID cases. And you have for reference other countries like the United States, Spain, Italy, United Kingdom, etc. So here you can see that in Latin America so far, we are at the bottom of the curve, thanks God, okay? And if we see the total confirmed cases per million people, we're still here, okay, down here compared with other countries with much more resources. I want to show you what is happening here in Peru, which is an interesting thing. This arrow is showing you the moment in which we started to do serologic tests. So because of the constraints of our health systems and our health laboratories, and because of the lack of availability of molecular testing, I mean, we were not able to buy it, even having the money in the markets, we started doing serologic tests. And we have been able to test almost 500,000 people. I mean, most of them with serologic tests, and doing something that most of the countries are not doing. So in general, we're testing more, and we're not only seeing, we believe, the top of the iceberg, but we're starting to see what is going on in populations. So we're testing populations of policemen, health workers, people that are working in markets, etc., to try to understand what is going on, and also to try to target certain conglomerates and areas of risk. So in the comparisons, it looked like we're having lots of cases, but I think we're testing lots and lots also with serologic tests. And we hope that that will allow us to have much better responses. So this is the number of confirmed deaths. You can see also here the cluster of Latin America compared with other countries and the total confirmed deaths per million people. And this is another interesting thing in the case of Peru, and this is the differences between definitions. For us, we are reporting deaths, even if people are having tests done with molecular tests or rapid tests. And this is a unique thing compared with other countries, not only Latin America, but in the world. So I would like to tell you a little bit about the good, the bad, and the gaps and the risks that we are seeing in Latin America. So first, the good. The speed of response to introduce voluntary and mandatory restriction policies had been really good in the country, and we learned from the international experience. We knew that we were having so many issues in Latin America that will not allow us to have a good response. We needed to have a low curve, and we have been pushing to flatten it. Okay, so we decided to introduce voluntary and mandatory restrictions. And the other thing that has been good has been the combination of public health responses with economic and fiscal policies to try to soften the socioeconomic impact on the low income and self-employed groups. This has been hard, but I think Latin America has put people in front of every decision. The bad, well, the bad has been the limitations with the supply side and the constraints with the EPPs, the molecular and the serologic testing, the intensive care unit capacities, and all of them have hindered the response. And the poor solidarity of the rest of the world, it has been so difficult. I mean, mainly the big countries, it has been so difficult with the small markets to try to buy EPPs or molecular testing. And that has led us to think of the importance of local production and trying to promote biotechnology in our own countries. The other thing that has been bad has been the different levels of compliance to the restriction policies. In the case of Peru, for example, by March 30th, although we were having this lockdown and the government started with these curfews, the number of people on detention and police stations for not staying at home or breaking the curfew reached 33,000. That was much more than the reported number of infected people. And that compliance had to do probably with cultural issues, but very importantly also with the need of people of going into the streets because they needed to get some money. They were from the informal sectors and they were having problems with food, etc. So that has been an issue. And the other issue have been the poor social support systems for the elderly that we have in our countries. What are the gaps and the risks? So we are seeing that there is going to be a problem on how to address the inconsistent observation of social distancing, isolation, quarantine, and other voluntary restrictions on movement that could lead to uncontrolled reemergence of infections or second waves. That's why at this point, most of us as Latin American countries, we're still locked down, where we are seeing how can we start moving our economy in a safe way? How can we return to work, but trying to assure that the social distancing and all the other measures are taken into consideration to decrease the risk of these second waves. The other issue is the potential spread of SARS infections to indigenous populations, especially the isolated tribes in the Amazon or certain communities in the Andean region. So finally, I would like to end with some issues that we have discussed as opportunities. Although Latin America has been and will be severely impacted with the global economic crisis that will follow the pandemic because of the decline in economy activity, in principal trading partners, because of the falling commodity prices, the drop in demand for tourism that has been quite important in Latin America and other things. There are other impacts in public health that we have to take into consideration, like the possible rise of unwanted pregnancies, mental health, domestic violence, or the worsening of chronic conditions due to the overloaded health systems during this pandemic. So although we have seen all these things, we think that Latin America will likely emerge from this pandemic stronger, having put in citizens and solidarity first and demonstrated the important value of strong public health systems. This pandemic has highlighted the need to work on regional channels of coordination for procurement of supplies, to strengthen intergovernmental continental cooperation in research, surveillance, and control, and also the need to promote regional development of biotechnology. And that is something that several of our countries are working on. Here in Peru, I'm chairing a commission that has to do with innovations for COVID. And we are starting to see, what are the kind of things that we need in research? We are part of a randomized controlled trial called Solidarity, working with WHO and several other countries to start to study certain drugs that could work for COVID. And we think that we're pushing also for the development of ventilators and other research that will be meaningful for the country. And we're trying to work with other countries in the region to try to share protocols, experiences, etc., because we need to come out from this problem stronger. We need to work on the effective articulation of public and academic health institutes and laboratories. And we need to work also on the effective training of human resources to be able to address better future public health challenges. So we're still fighting and we're still struggling. We're trying to see how we can do it better together. And that's it. And thank you very much. So Keith, it is your turn.
Thank you very much, Dr. Garcia, and those are 3 fabulous presentations. So we're going into questions and answers now. So if you have any questions, please list those questions, send those questions in to us into the chat box. So the first question is going to go to Dr. Torto, and I'm bundling some of these questions together. So Kirsty and others, Dr. Torto wants to know how are the research that's coming out of COVID-19, how is that going to benefit African countries, and how can that be utilized to build capacity in African institutions? Is there a way to leverage these investments to address chronic areas of inequity in terms of research? Over to you, Dr. Torto.
Thank you very much for the question. Clearly, our efforts at the African Academy of Sciences is really to provide a resource for the continent. A resource, firstly, in terms of coordinating the activities of the researchers. And in that respect, we are also doing that by trying to provide support in terms of funding that they can have so that they can be able to drive some of their activities at a faster and higher intensity rate. The second aspect is that we have got a program that is called the prioritization program, where clearly we want to be able to engage with governments. We engage with the regional economic communities to try and see what are the key aspects that affect their respective areas. As you know, Africa is a very, very big continent in terms of land mass, and clearly the priorities in East Africa are not the priorities in the southern part, and obviously there are different cultural issues that come into play. So we are engaging in that to be able to make sure that we are relevant in terms of the efforts that we put. And lastly, we are also working at the African Union level. There have been quite a few webinars and meetings that involved ministers responsible for science and education. And we have been contributing to those meetings in terms of actually giving information that relates to some of our findings as we have been conducting these webinars. So we are hoping that our efforts in those levels really will help governments realize what they need to do by when, because we are helping them in terms of prioritizing their efforts towards addressing the issues of COVID-19. And of course, I think one of the key issues that has come on board, which we have been trying to engage through one of our clinical trials program, is that we know that Africa does not have the capability of doing clinical trials, or African countries are not involved in clinical trials. So we also want to try and see how can we enhance that, so that if there was a drug, for instance, would that drug work for the African population, and if it would work, how would we prove that it works, and who would we engage, and how would we go about the process, and who should we contact? Again, that is a key aspect, because I think, as has been related from Latin America, that the testing aspect is a very key aspect, but also when it comes to treatment, we need to make sure that whatever vaccine that will come, will have relevance in the continent. Thank you very much, Keith.
Thank you very much, Dr. Torto. And Professor Dudley, this question is for you. It's from Azima and others. And Azima wants to know about the issue of access to hand washing and clean water, particularly in low income areas like Kailicha and in rural low resource areas. How difficult is it for these communities to access soap and clean water, which we know is so important in terms of trying to bend the curve on an infectious disease like COVID-19?
Thank you for that question. So access to running water, reticulated water, and waterborne sanitation and soap is very difficult in informal settlements. Even though some places may have a single tap to a household, most households have to share taps. So they would be outside, and they would also be sharing pit latrines and other types of toilet facilities. So it does become very, very difficult for households to practice hand hygiene and to comply with some of the requirements, let alone having access to hand sanitizer, for instance. So these have been some of the challenges that communities, particularly in informal settlements, as well as in other urban areas in the cities, where many households have backyard dwellers, so would have 2 or 3 or 4 other households living in shacks in their backyards, sharing the main household's water facilities and toilet facilities.
Thank you, Professor. Thank you very much, Professor Dudley. Dr. Garcia, this is for you, and you have a very unique perspective by being not only a professor in university, but also a former Minister of Health. From your vantage point as a former Minister of Health, what were some of the biggest challenges that you saw being a former Minister of Health to being able to operationalize some of the public health interventions that you fought for as a minister? Can you share some of those challenges and in your experience and how we can overcome them?
Yeah, well, and related to COVID, obviously, right? So one of the issues has been our poor laboratory capacity across the country for molecular testing, okay? And one of the things that we're trying to do to try to overcome that is to include laboratories, academic laboratories that had recently, in the past 2 or 3 years, been implemented through the National Council of Science and Technology with equipment. So although the public health do not have laboratories, now we have these academic laboratories that can be doing molecular testing. So that still is, I mean, it's ongoing, okay? And so because of our lack of capacity for testing, is that we had to introduce the serologic tests that have been quite helpful, but we know that there are limitations also regarding that. The other issue is, which has been also complicated in order to introduce public health measures, is the fragmented health system that we do have. So we have the Ministry of Health Services, we have the Social Security hospitals and clinics, and we have a very small private sector, okay? And the capacity of the Ministry of Health Services have been always limited. So we're trying to work as a whole right now to serve the people, but the number of ICUs, the number of ventilators that is low, and that has been really problematic. The third issue I will say is the fact that we have not been able to create real networks into the community to assure the messages that we needed, okay? But regarding COVID, and as it was mentioned in Africa, I mean, it has been incredible the number of fake news and the use of social media to disseminate all kind of things. Okay, how we have been able to overcome that has been by working with the formal media, okay, TV, radios, etc. That has been incredible. At least here in Peru, they have all aligned, and we have been trying to bring the right messages to the people. So I think what we are living is showing us right now all the weaknesses of our health systems, and I hope that in a way we will be able also to use all these weaknesses to try to improve them. The final thing is we have seen this weakness in the development of biotechnology and all the bureaucratic steps that we have in the government to procure supplies or even to get approvals for any type of research that you will need to do. And I'm saying this because we have been trying to do for the randomized control trial. I mean, we had to work over several weeks to try to be able to establish the randomized trial and also to be able to reach the different health centers around the country that were not used to the research. But so we're trying in the middle of this whole situation also to try to create capacities in that sense. Over to you.
Thank you very much, Dr. Garcia. We're going to do one more round with Dr. Torto, Professor Dudley, and Dr. Garcia. We'll have a wrap up of a point for each, and then we'll close everybody. So, Dr. Torto, this is a double barrel question for you. And just, Dr. Garcia, thanks for pointing out all of us as scientists need to speak out against the fake news that is so destructive to people's health. Thank you for mentioning that. Dr. Torto, this is a double barrel question for you. Anamia has a really quick one in terms of, can African researchers who previously received funding from the African Academy be eligible to apply for COVID-19 related research funding? And then the second part is, if you could just speak again to the massive food insecurity challenge that's facing the continent this year, with hundreds of thousands of people possibly dying by the end of the year. Over to you, Dr. Torto.
Thank you very much. The first answer is yes. Yes, people that have been previously funded by the African Academy of Sciences can have access to the COVID-19 funding. Obviously, this will be a very less labor-intensive task from our perspective, because we want to make sure that dealing with people that we have already assessed in various ways, and therefore we can easily get to the point where we can be able to fund them, without having to do the unnecessary due diligence. In terms of the second part, I mean, the issue about food, I mean, that's a great concern, isn't it? That's a great concern. It's a great concern from various parameters. First, from a climatic perspective, I mean, we've had heavy rains all over in the continent, and of course, those heavy rains are not necessarily good for crops. But that's one thing. The second thing is that we can look at it from the fact that we've had obviously an outbreak of locusts that have been destroying crops, partly in the eastern part of Africa. We haven't actually gotten any down in the south. But again, it means that whatever crops have survived the rampage of the rains, etc., they will have been destroyed by the locusts. But I mean, the other thing, the third aspect, obviously, relates to the breaking down of the chain of food supply. Because of the fact that most of the countries now are under lockdown conditions, it means that the food supply chain process has been broken down because of the fact that the farmers are not able to do the farming, they're not able to collect the crops. Some of the crops are perishing in the fields. Even if you get the crop in the fields, then there are issues in terms of mobility, because most of the country's mobility has been restricted. In Botswana here, for instance, we have divided the country into different zones. So there are some zones where there are hotspots, and there are some zones where it's not hotspots. So clearly, again, this has got an impact on the food supply. So it's a very big challenge for the continent, and obviously, like it has been said, there are people that live from hand to mouth, and the fact that they are not able to go out there and do the work that will bring them money for food for the day, that is a great concern.
Thank you very much. Thank you, Dr. Torto, very much. It certainly should be a red flag for the world. Professor Dudley, this question comes about concerning tuberculosis and people staying at home, and you mentioned obviously the high incidence of TB in South Africa, but also worldwide is the #1 cause of death from an infectious disease. Can you share with us any mitigating factors, mitigating efforts that have been done to reduce the transmission of TB while people are being forced to stay in their homes?
Okay. This is a huge concern as well in South Africa, because the routine health services have been interrupted and fewer TB patients as well as HIV patients are in fact collecting their medication. So we are finding that adherence to treatment has deteriorated, and are anticipating that morbidity and mortality related to TB and HIV is going to be worse in the coming months. Efforts that have been made to try and address that is health services have actively tried to follow up patients. Community health workers have gone to visit known TB and HIV patients to try and deliver medication where people haven't collected their medication. But at this point in time, I can't comment on the extent to which that has effectively addressed the treatment adherence challenge. And at the same time, health services are also not doing any new case finding. So we're also anticipating that many new TB infections are not being picked up, and do anticipate that the TB incidence and prevalence may increase in the future as well. So not good news all round.
Yeah, thank you very much, Professor Dudley. It certainly isn't. And finally, to Dr. Garcia, and each of our speakers will have a chance to have a closing minute after Dr. Garcia responds to this question. And this webinar will be on CUGH's website, cugh.org, and it'll be up within 48 hours. So you're welcome to look at it at that time, and please do share it widely. Dr. Garcia, this last question is for you from USMA. You mentioned in your comments about the economic policies that were taken particularly to address the needs for low-income communities in Latin America to soften the socioeconomic impact of the pandemic on them. Can you share some of those initiatives or policies that were taken by Latin American countries to do just that?
Okay, there had been several actions taken by the different countries. I can mention, for example, what the Peruvian government has done. The Peruvian government has set aside about $85 million dollars for small businesses, $57 million to Social Security, and then bonuses for the people that has from low socioeconomic status, bonuses that were given in at least 2 or 3 different points of time. People that do not have any Social Security or are part of the group that receive the comprehensive insurance of the Ministry of Health. There had been also other, and countries have been using this type of bonuses, okay, to people with no resources at different points of the epidemic, trying to fight the situation in which people had to go out their houses to sell or because they don't have anything to eat, basically. So I guess countries have been doing what they were able to do depending on the possibility of their fiscal space or the fiscal cushion that they had.
Great, wonderful. Thank you very much, Dr. Garcia. And finally, we're going to go in the reverse order, and each of our speakers will have a chance to make a closing comment. Dr. Garcia will turn it over to you, then Dr. Dudley, and then finally Dr. Torto. Dr. Garcia, over to you.
Thank you. So what I tried to present was the experience that we have had in Latin America. Of course, we're countries that have several similarities, but we have also some differences between us. But as you can see, I think one of the messages from the countries is that in this pandemic started early with things that had been able to help us, taking into consideration all the limitations in our health systems and several characteristics of our populations. We will see what happened in the next months because, I mean, this is an evolving issue. We are concerned about the possibility of accessing drugs if a drug shows to be effective. And we are also very concerned about access to vaccines. And we are part also of a network discussing the issues of access to vaccines, which is, as we all know, probably will be the only real way to get rid of COVID. So one of our biggest concerns, again, is how can we assure the access for such a thing as vaccine for all the regions that need it, okay? Latin America, Africa, and the rest of the world. I think we need to think as a global community about that. We all will need it, and it shouldn't stay only in those countries that can pay for it. That's a real concern. Thanks.
Thank you very much, Dr. Garcia. Professor Dudley, over to you.
Thank you. So in our experience in South Africa, I think what has really hit home is the incredible social and economic impact in addition to the health impacts of COVID-19. And it's certainly been useful to hear from other regions and other countries' experiences because this is something which many countries in the North have not had to address to the same extent. And it would be useful if we had more opportunities to share some of the regional experiences as to how one mitigates this as we navigate the next year to 2 years of this COVID-19 epidemic. So certainly for me, an opportunity is to have more regional collaboration and learning, and also linking up with research and innovation to begin to look at strengthening regional capacity for research and innovation to improve our own reliance or self-reliance around medical products and other requirements that we're going to need to get through this epidemic. Thanks.
Wonderful. Thank you very much, Professor Dudley. And Dr. Torto, you have the last word.
Thank you very much. Thank you very much for the opportunity. And I want to agree with my fellow panelists in terms of the issues that they've raised. We at the African Academy of Sciences, our focus is really the scientists, and beyond the scientists, we are focusing on issues that can impact lives for Africans to live a better life sooner. And obviously, we want to engage with governments, we want to engage with policymakers. But I think what is very clear from this discussion is that the COVID-19 has again demonstrated that the world is so far apart, and yet we are a one entity in the sense that what affects the Chinese does eventually affect everyone else. So, I mean, the need to collaborate more, the need to work together more, I think it's something that would be key in terms of how we go forward. And from our perspective, we consider ourselves as a go-to entity in terms of issues relating to science, technology, and innovation. So we will be happy to partner with whoever wants to partner in terms of looking at funding issues, in terms of looking at dissemination issues, where we can share information that has come out of some of these experiences so that the society can be better prepared for what can ever come in the future. Thank you very much.
Thank you so much. And I'd like to, on behalf of CUGH, I'd very much like to thank Dr. Garcia, Professor Dudley, and Dr. Torto for their expertise in sharing that with all of us. today. And I'd like to thank Jenna for producing these webinars, and she does a fantastic job. This COVID pandemic is certainly a massive challenge, but as we've heard today, it also presents an extraordinary opportunity, an opportunity for us to work together, to collaborate, to be able to address these persistent challenges, to be able to address the social determinants of health, strengthen public health systems and public institutions which underpin and gird the ability of any country to improve the health, welfare, and security of their citizens, to address the environmental degradation that has underpinned the spillover of this and other zoonoses, to strengthen the global health security agenda, and finally, to address the non-communicable diseases that are responsible for 70% of deaths worldwide. On behalf of CUGH, I want to thank you very much for tuning in today. This webinar, as I said before, will be on CUGH's website at cugh.org. It is open access, and we appreciate it if you could share this worldwide to be able to share the expertise that you've heard today from our three wonderful panelists. Thank you very much, everybody, for joining us today. Bye-bye for now.